computer. All right, everyone. Hi, and welcome to another ANID webinar. My name is Lynn Slosky. I'm the Executive Director for ANID, and I'm delighted to be here today with Dolores De Vargas-Schoonover. She is going to talk with you about binge eating and eating disorders within the Hispanic, Latino, Latinx culture. And we're delighted to have Dolores. She's a primary therapist at EDCare, and we're so grateful to EDCare for sponsoring this webinar and overall for the amazing support EDCare has provided over the last few years to ANID. Just real quick, for those of you who are new to ANID, who maybe came to us through EDCare, welcome, hi. Here is a little bit about what ANID does. Of course, go to our website, anid.org for more information, but we are providing free peer support services to anyone who is struggling with an eating disorder. That includes support groups, mentorship, helpline support, and referrals. Currently, all of our services are provided by trained volunteers with lived experience who have walked the road of recovery and can relate to our beneficiaries. And they experience a lot of services throughout their volunteership, including live training sessions, volunteer supervision sessions, continuing ed sessions, and ongoing support as needed. So if you know anyone who would like to be a volunteer support group leader, a volunteer mentor, call a helpline volunteer, we would absolutely love to talk with you. We're launching volunteer recruitment next week on Monday. And so if you or anyone you know is interested in being a peer supporter, please reach out to us. All right, then I will get on to the housekeeping of this webinar. So we're probably all familiar now with chatting in the chat box. There's also for this webinar, there's a Q&A, so you can put your questions there or in the chat. I'll be monitoring both of those throughout Dolores's lecture, and we'll save all questions for the end. We'll have about 15 minutes at the end. So you can feel free to write your questions as you think of them. And if I can answer some along the way, I will, but otherwise we will save them for the end for Dolores to answer. And then this afternoon, you'll receive the recording of today's webinar, as well as tomorrow you'll get an email. Notice this email is not from ANID. Whoops, sorry. It's from oakton.edu, and you need to complete the evaluation that you get in that email to get your CE certificate. So any questions about CE credits, you can just type them in the chat. I want to move on at this point to introducing Dolores and letting her get on with the show. So Dolores De Vargas-Schoonover is, plus all of her suffixes, she has a lot of educational background, which is fantastic. But Dolores is a bilingual professional counselor with extensive experience in working with individuals very resistant to treatment, history of trauma, eating disorders, neglect and abuse, substance abuse, poverty, and homelessness. So that's really, really great experience that Dolores is bringing to this presentation today. Dolores received her Bachelor of Arts from Regis University in the area of Spanish and secondary education, her Master of Arts in Counseling Psychology from the University of Colorado, Denver. Dolores believes that the family unit is an important component of the recovery process and incorporates family systems theory. Dolores values meeting the needs of each patient's individual treatment. So with that, I am going to stop my share and allow Doris to share her screen. And then I'll go off camera, Dolores, throughout your presentation. I'll come back on for the Q&A.
Lynn?
Yes.
It says I'm disabled in screen.
Okay.
Sharing.
My bad.
Thank you.
Okay, try now.
Got it. I think. Yes.
Perfect. Yep.
Well, first of all, I want to say welcome and thank you for attending the seminar. For my bilingual colleagues, bienvenidos. Gracias por atender mi presentación. I hope that you all gain some much needed knowledge and experience with a population that we see as still underserved and minimal research. As I go through my presentation, I'm going to say that over and over, that there is still, as I go through my presentation and you look at my research resources, that this is an underserved population, but not only as far as services, but also as far as even finding research. So I want to stress that as I go along. And I will start off by reading the objectives.
And Dolores, if you'd like to, yes, go and just, yeah,
Right.
perfect. Okay.
Yes. So my focus will be on psychoeducation so that you as an audience is aware of the binge eating disorder and specifics to the Hispanic population. And additional information is how binge eating ties in to other eating disorders, or it will be approached along with symptoms, diagnosis, cultural approaches, obesity, binge eating disorder, and treatment methods. The various eating disorders will be explored to connect them to binge eating disorder. And as we look at binge eating symptoms, those of you in the field of treating the different diseases, I put them up because I think if we don't treat binge eating consistently, we tend to forget what the DSM lists as the symptoms. These are episodes within a period of time that is discrete food or foods consumption that is more than what the normal person would consume. That feeling and out of control, embarrassment, feelings of guilt that lead to more behaviors. And what I think the DSM should add on there is many feelings of shame that perpetuate the cycle. These episodes occur at least once a week and lasting 3 to 6 months. The gravity of the symptoms, the mild, as you may have straight out of the DSM, mild form is 1 to 3 episodes per week, moderate 4 to 7 episodes, and then severe are the 18 to 13 episodes per week, and the extreme are those 14 or more. What we don't hear often with this disease is that binge eating is the most common in the US, the most common eating disorder among teens and adults. And the cause of binge eating disorder is unknown, and yet it's generally linked to social, biological, or psychological factors. And I cannot stress enough the consequences that occur with this disease that are equally as dangerous as any of the other eating disorders that we treat. Those consequences can include higher weight, high blood pressure, heart disease, diabetes, obesity-related illnesses. And I can also stress that even some binge eaters who use other compensatory behaviors are normal weighted. So oftentimes they get a different diagnosis because of the normal weight, yet their primary behavior is binge eating. The part that I mentioned at the onset of the presentation was that the DSM doesn't include the amount of shame that our patients experience with binge eating and the ongoing mental health concerns that often are not addressed. When I researched the history of binge eating disorder as I did this presentation preparation, one of the ones that popped out was healthline.com, where they talked intensely about binge eating disorder is not new. The first case was discovered in 1959, yet we don't talk about it. we hear about anorexia nervosa, we hear about bulimia, we hear about even orthorexia, yet binge eating tends to be less addressed. In 1987 was the first time that binge eating was put into the DSM, yet it was put under bulimia nervosa symptoms. And treatment prior to this was very difficult. Thankfully, in 2008, a new group was formed for advocacy for this population. And this is when the Binge Eating Disorder Association was formed. Again, in 2008 was when the Binge Eating Disorder Association was formed as a means of support and advocacy. And looking at that disparity of when our first case was first mentioned in 1959, and nothing came through for advocacy till 2008. Finally, in 2013, the DSM-5 put it in there as its own diagnosis. And oftentimes I think it's still overlooked. Again, with a normal weighted patient that uses other behaviors to compensate, binge eating can be the forgotten disease, for lack of a better way to put it. In 2015 was when the FDA finally approved a medication that is fairly effective from what checking with the psychiatrists I work with, Vyvanse, which is also used for ADD, ADHD, was approved by the FDA. Again, looking at the disparity, 1959, the first case was discovered. 2015 is when the first medication was approved to treat this disease. I think back to when I was working on getting my eating disorder specialist certification and reading through one of the books. It talked about how binge eating was around in the 1800s when we talk about gluttony and the kings and how it was seen as gluttony versus the emotional piece that comes with this disease.
Dolores,
So again,
Dolores, yes. I'm so sorry to interrupt, but could you advance your slide to, I think maybe.
We're still on 4.
Oh, okay. Okay.
Yeah. Yeah. I was just using these as continuing to talk about binge eating and the history.
Okay. Okay.
So now we're on 5. So when we look at anorexia nervosa and prevalence is 0.08, bulimia is at 1.161, and then we look at binge eating disorder, 1.92. So binge eating disorder is the highest eating disorder disease, with bulimia within the Hispanic population, or in general, excuse me, with bulimia nervosa coming in next. The Hispanic Latino statistics, if we look at as Latinos, 1.9% struggle with eating disorders. Women, a larger portion, 3.5%. Males, 2%. And the general population, if we look at this slide, along with binge eating, bulimia nervosa is on the rise, and yet there are more studies available on anorexia nervosa, even with binge eating being the more prevalent one. And I'm continuing on this slide to give more information. Though there are more similarities than differences with the general population or non-Hispanic whites, in general, binge eating disorder among ethnic groups is fairly high. Hispanics, I will explain a little bit more about the terms that I used in my title. I shared with Lynn the part about how I identify as Hispanic because of the various populations that have lived in various parts of the US. So I am originally from New Mexico, where we are a blend of various cultures. So I identify as Hispanic because I identify with my language of being Spanish. Latinos identify as those individuals who who would say they are more from the Latin American countries. And Latinx, as I included on here, is related to gender neutrality and in individuals that use this in both Latin American culture and the US. I stress this piece because I think when you're treating someone from this population, there has to be that awareness around how do they identify. And one of the stress points for me here is that the American Psychological Association reported in July of 2021 that there are 60 million Hispanics in the US. We make up 18% of the US population. We identify as Hispanic both as our primary language and as our racial makeup. Belonging is part of our mental health and well-being. So again, I cannot stress around how this is a larger population that continues to grow and could very well at some point be the majority, and yet underserved, underidentified, undiagnosed in certain areas. What do we know about Hispanics and eating disorders? So what we know is that there are similar proportions of bulimia nervosa and binge eating disorder between Hispanics, Latinos, and Caucasians. Binge eating disorder is the most common eating disorder among Hispanics. Studies show that within the United States, Hispanics, we rarely will seek treatment. Discrimination can be attributed to binge eating. In addition, overall, eating disorders within this population, as I mentioned, is the same as Caucasians. And as this minority group arises to be the majority, there's higher immigration rates. It makes it a group that is living between two value sets, something that is also important to be aware of. Shame and guilt are highly experienced within this culture when it comes to mental health. And then you throw in a disease that can be very much body focused. Food in my culture, in this population, is a means of bringing us together, past, present. It's a culture itself. It's ownership of our traditions and our cultures. Hispanic women experience binge eating disorder almost as much as the general population with binge eating disorder alone. There is still an ongoing stigma about receiving mental health services. Each generation reacts differently. Eating disorders often go undiagnosed or underreported. Prior to the DSM-5 bringing in the last few years prior to this disease being part of the DSM a few years ago, it was only addressed as a medical condition. One of the things I say in general when I talk about with some of my patients, and I've treated both at EDCare, I treat both Hispanic and non-Hispanic. The one thing that I always talk about when they tell me I'm coming here because I've tried every diet on the planet, I always say, was the emotional piece to your eating ever addressed? So in general, that's, I think, where things have slipped, in that when you look at the stigma to a mental health disease with this in general, with binge eating disorder, and then you go to a doctor who's saying you're overweight, you need to go on a diet, and the emotional piece is not addressed, then it's a cycle that continues to repeat itself. And again, I'm going to stress the piece about there is a stigma still within this population, whether it's Caucasian, Hispanic, or other ethnic makeup, that we really need to be aware of. This age did what age did this person come to the US if they immigrated here? Because again, as I mentioned earlier, there may be two sets of values that are being explored. Here I come, and I'm using Mexico as an example because I have treated patients that relocated here from Mexico, as well as one from Chile, whose views are very different. So we have to take in that into consideration. I use an example from many years ago of treating an elderly woman who had binge eating that eventually turned into bulimia. Her journey was such that it started from postpartum depression, yet there was some trauma that was unreported. So again, looking at the whole picture, as we look at this slide number 9, and level of education. We were just talking here about level of education, being able to work at the level of that person. Many people who immigrate here generally don't have any more than elementary school. Primary language. I think that is one of the biggest struggles that a lot of patients have experienced. People knowing Spanish. And I say Spanish because that is the primary language of Hispanics, Latinos. Food, as previously mentioned, the culture is all about food. There are so many rituals related to food in the culture. It's that piece of, it's a birthday party, it's food focus, who's bringing what, that's a big conversation. What are they cooking, who's getting together? It's very much, again, about the culture. Remembering the socioeconomic struggles of all populations, but when we look at this culture in particular, we have to explore their struggles and the access to healthcare and mental health services in general. There is still that fear that often comes with the immigrant or first generation here of asking for help. And am I going to get in trouble because I'm sick? When exploring body image distress, there is a direct conflict, as often this population, as mentioned earlier, is more accepting of the hourglass shape or body. Like other cultures, there are other contributors, contributing factors such as media that can promote thinness, but generally it is a culture that accepts the hourglass body. Really having awareness about generational influences that can be impactful. When talking about body image, I always use the example of generational and cultural occurrences that are often common are the use of nicknames within my culture, and they're often related to bodies, to what our bodies look like. There's names such as el gordo, la gorda, la flaca, el flaco, el moreno, la morena, and those are all descriptors. It's the fat one, the skinny one, the darker one that we need to be aware of. I remember many years ago having to deal with it from someone that was not from, was Caucasian and involved with it through family in a Hispanic family, where there was a lot of talk around what they looked like. And these were the names that were used to describe them. And oftentimes in treatments, I've had to really make them aware of, this may be something that is endearing to you, but with someone who struggles with shame and guilt, finding other ways to connect with them in an endearing way is far more appropriate and healthier for your relationship than using body descriptors, because that can perpetuate the eating disorder. This type of talk or lessons, it lessens as acculturation or assimilation occurs, or depending if the person immigrated here or was born here. Again, generally as they acculturate or assimilate, a lot of these talks lessen, and they're more appropriate in how they approach body image. Due to binge eating disorder being more common in women, there's a potential for discrimination. When I was doing this presentation, preparing for it, studies showed that up to 7% of women with a binge eating disorder have experienced discrimination, and it is likely related to their body. As we continue, we go into what we need to complete an assessment. An evaluation needs to occur between a therapist and the patient and family. When I talk about an assessment here, it is important to really, really look at, regardless of the population, that often assessments are self-reports. And in this case, it's important to include the role of the family system. As you all can see, I treat my patients from the family systems theory, and not only because that's my theory of choice, but in this particular population, extended family can include many, many people. If I share about my own family of origin, I have 7 biological siblings, 1 adopted brother, and a cousin that was raised as a brother, and many other cousins that were in and out of my house. Similarly, it still occurs within this culture. So the role of the family system is a very important part when completing an assessment. This can include, the culture includes family being anyone living in the home, whether they are related or not, extended family, which I describe here in Spanish, the tios, the tias, the primos, the padrinos. These are the aunts, the uncles, the cousins. The role of godparents. Godparents is a, regardless of the religious affiliation, this is a culture that godparents exist for the majority of every family that I've known, whether you're, regardless of what you affiliate yourself. Godparents play an important role because they are the ones that have agreed to being part of the extended family if something were to happen to the parents. And this is a lifelong relationship in most cases. Along with including the extended family, this could be community that may be their support system, including their religious or spiritual leaders. It could be someone that they lived with and consider a second parent. I know on our intake, we often ask, who else do you include in your family of choice? I think it's important when you're completing an assessment, who else is a part of your family of choice? You know, looking at what their support system looks like is very important with this culture. It's important to explore core beliefs within the culture and what their experience has been with the mental health services, if any. Oftentimes, I've had to dispel the myth that only locos or crazies go and get help. I've even heard the word when I've been doing an intake and someone isn't aware of a person's experience with suicidality, questioning that person. And I often have heard, ¿Estás loca or loco? Are you crazy or what? So really having that awareness that there may be some secrets going on they may be more protective than actual secrets because of the response to mental health. So really looking at also what medical services have they gotten. Oftentimes, you're going to be the person that they look up to. As we look at also that piece of what your role will be, if we look at mental or mental health concerns, we did not recognize it as a mental health concern for many years. So many still feel uncomfortable with it, or more comfortable viewing it as a medical issue. Also, the culture will be more open to the medical versus mental health view. So there may be some resistance that you come across initially. So as a therapist, I can't stress enough how important the relationship with your patient is going to be. Remembering that piece, that once they form a relationship with you, you are always going to be seen as the expert. As you can see, I'm not a doctor, I'm not a PhD, I'm not an MD, but I have been referred to as the doctor or la doctora, because again, that relationship is established, therefore you're the expert. Dieting and acculturation or assimilation go hand in hand. Recognizing that in Mexico, some medications that are prescribed here are very much available over the counter, these being diet pills. So really getting some knowledge around what have you used in the past around trying to control your binge eating. I stressed on here that as a dietitian, if I have any of my colleagues out here who are dietitians, when I presented this here at EDCare, I had some head nodding, that much like ketchup is a condiment for a lot of us who grew up here or have used it as a condiment, salsa and chili are part of the culture. There are patients that keep their salsa or their bottles of Cholula on the table. Having that awareness that that is a condiment, unless you've assessed it well enough to know that it's actually part of a behavior. So having that awareness even may require that you switch around some of a patient's meal plan. As I continue to add on the assessment, remembering the piece that the food is viewed differently in the Hispanic culture, and it might be in other cultures. I'm stressing it in this culture, that get a good sense of for how food is viewed. Often food is a nurturing, soothing celebration and reward for, in many instances, common practices. Similar to other cultures, offering as food is common and usually the go-to in the Hispanic culture. I don't know how many gifts I have received during the holidays that are about food. And so it's important to be able to also know if you're in private practice, following your guidelines around how you feel ethically about receiving food, how your agency or your practice in general feels about receiving food, but it's often a gift that's shared. Remembering too that food is seen as love, nurturance, and this is shown through food, cooking, connection within the culture. It is not uncommon for patients that I've worked with to say, what am I gonna do? It's Christmas time. This is when everybody gets together and we make batches and batches of tamales that we will eat Christmas Eve or New Year's Day. So again, if someone's assimilated or acculturated and still, dealing with two sets of values, how do they fit this into their meal plan so they don't experience the shame and guilt? I stress too that having awareness of your patient's living arrangements needs to be explored when we're doing this assessment, because oftentimes it's not uncommon due to socioeconomic struggles that others may live with them. How do others in the household approach food? It's common for extended family members to live together until they're able to be on their own, often necessary and encouraged. So being aware of that, sometimes it can be viewed as enmeshment, and yet it's also out of need. And also when we look at the mental health experience, older generations may still believe in the use of spiritual religious leaders, along with having the thought that the family will take care of it. It's not a secret, it's a cultural view. When I look at the family system, I'm still on slide 10, really looking at how is mental health approached. Though it's often, the Hispanic family is often portrayed as a patriarchal family. Often the mother is the one in charge of any kind of illnesses, even in a non-traditional family where the mother works. It's important that regardless of the age, we look at how does the family system approach medical and mental health issues. They can be viewed, again, I'm saying this, oftentimes if you don't know the culture or the family or the person you're working with, it can be viewed as an enmeshed family system, yet it's the role that's taken by the culture itself. Within the family, it's the mother who is often in charge of taking care of appointments, whether the mother works or not. And often most mothers that I have worked with now, even as if they have an adult child with an eating disorder, they're usually the ones that attend the appointments. It's not uncommon. It's also, in addition, I want to stress to be aware of the struggles that may cause stress when getting to appointments, whether it's individual appointments or group appointments. Socioeconomic struggles are real, not just for this population, but in general, I think a lot of people are feeling it now. In addition, older generations may still believe in the use of those spiritual leaders. They're still curanderas. They're still the lady down the street in smaller communities that people go to and get their herbs from. Some of these herbal teas that are commonly used can still be picked in some of the smaller towns in New Mexico. There are herbal teas grow wild. Some of these teas could include yerba buena, which is peppermint tea, manzanilla, which is chamomile tea, and feeling that the family will take care of the situation. We need to be aware of that. There's still that part of, we'll take care of it, we'll take care of it. You know, have you tried this? Have you tried that? And often it's herbal teas. So having that in mind, that they may try that, some because of the stigma to mental health, but also because of the stress that's associated with having transportation or a means of paying for treatment. I have worked in the past with some patients where there's 3 or 4 other people in addition to their family living in the system, where there's not a role definition on who's cooking, who's cleaning, who's doing what, and then it creates more stress for my patient. So again, completing an assessment is not just sitting with your patient and evaluating, doing a self-report. It's taking more time to really, really look at what else is going on within the culture. So we move on to interventions for binge eating. What we know is that binge eating can be treated both individually or in a group setting. The most common ones used are cognitive behavioral therapy, and as I put on my slide here, it is the only therapy adapted to this specific population. I will add to it as we go through this slide. DBT, or dialectical behavioral therapy, is also used, behavioral weight loss, and medication management. As I said, CBT and DBT are the most common used or recommended therapies to use. CBT is the only one adapted to the culture, When we use CBT, we know that it has been adapted because it focuses on the core cultural beliefs, which I have been saying consistently, that really, really being aware of the cultural beliefs to have a successful outcome with a Hispanic patient with binge eating disorder. Skills are connected to the culture and the use of language is incorporated. From my perspective, CBT and worksheets are easier to translate. DBT, though successful, you have to have someone that really, really knows the English language, because Dear Man is not going to translate exactly to Spanish. So really having awareness. And when we talk about behavioral weight loss, we do talk about the concerns due to it creating metabolic issues in the future. In addition, what's come out of some of the behavioral weight loss programs is that from this, we know that healthy at every size groups have expressed ongoing concerns, and the focus needs to be on self-acceptance. Weight loss interventions do not have a high success rate. Often leads to returning to binge eating due to restricting or disordered eating is perpetuated. Some medications have been explored, such as antidepressants, and they're actually more accessible. Yet again, we have to look at what is this person's access to healthcare and also for payment of these medications. And also, when we look at medication intervention, there are few treatment providers that are trained with binge eating disorder. There have been other considerations that as I researched for this presentation that have been looked at that included acupuncture and a combination of all. Again, for me, as someone who has treated binge eating disorder, for me, cognitive behavioral therapy has been the easier to use because it is easier to translate. Excuse me 1 second. As we look at the specifics to the interventions, some of the research that's come out of it is that CBT, it requires the working on the relationship specifically to the feelings, behaviors, and restructuring the negative feelings about self. I think if you've used CBT enough, it's sort of what was the activating event, what was the feeling, how strong was the feeling, is there another way to look at this thought? And so looking at CBT is that relationship between feelings, behaviors, and looking at the negative thought that comes about ourselves. Individual CBT involves that psychoeducation with a therapist, learning new skills, and ongoing support. Partial one-on-one involves both work coming in for individual sessions and group sessions, which can include video recordings to review in sessions. So again, these are both easier to use, again, CBT, because it involves also doing work with your therapist. When we look at interventions, again, that structured self-help is used with a manual in a peer-led group that can include videos specific to the use of CBT. So again, it's that use of structure, which we know is also part of curtailing binge eating behaviors, the structure of meals, structure of skills, and learning them in a structured setting. Self-help is around using the manual, which CBT has many, many manuals, self-based with the therapist providing guidance. The good part about a lot of the self-help, you can also be done in person or virtually. When we look at DBT, it involves your client understanding that impact of the negative feelings that led to the behaviors, and how the behaviors have become a means of coping. Mindfulness. I think when I look at DBT and using it in the mindfulness and how the culture approaches a lot of that spiritual side, I think DBT can be used if you incorporate the spiritual aspect that the culture sometimes can be very open to. The regulation of emotions and tolerating emotions is the focus. DBT can be used individually or in a group setting. I think the part with DBT that I find interesting is that you can actually show this. I've actually used some mindfulness and regulation skills with a partner. It can be used as a way for them to connect with each other. So that interpersonal psychology, we look at what's activating the events, what led to the binge eating behaviors, and that this became a way to cope versus really working on learning to cope with feelings and emotions, generally negative. Clearly, I think with binge eating, if you look at the shame and guilt, something precipitated the behavior and then it continued through the cycle. And with interpersonal psychotherapy, you can either engage individually or in a group. Behavioral weight loss. We can talk about how it includes working on the behaviors that are leading to the restricting of calories, exercise that can lead to weight loss. I think, again, when I look at the behavioral weight loss, is that what we know about dieting is that 95% of patients or people that diet, their diets don't work, and they can lead to more behaviors. So I always caution the use of this. Excuse me. Oops. I'll give you a little more information around these specific behaviors when it comes, interventions when it comes, again, with DBT. The part about it is that it's not easy to translate from English to Spanish for the use with our patients. Also, DBT was less effective in the area from my research that I found in the area of the eating disorder behavior reduction and related to self-esteem. What worked was the incorporation of emotional regulation skills that DBT incorporates. And also the part about DBT is it is less time consuming. You can do a workbook, and then you also have to have a patient that is pretty motivated to work on these skills on their own. What we know about CBT, it has been shown to work with clients being more aware of their triggers. And so I think it's also working on that. What was the event? What precipitated the event? So structuring the patient to really, really look at what are we dealing with when these things occur. And then obviously with CBT, we also stress the need with having structure with meals, which is what is in general required for the decrease in binge eating behaviors, is structured meals, also looking at emotions and the physiological needs, what led to the behavior, which CBT is very much a focus on. Again, I stress that piece of what led to the behavior, what are the feelings, how strong is that feeling, is there another way to look at this thought. Follow-up studies with CBT have also shown that CBT has worked well with family as a peer support for their loved ones. If they struggle, they now can work together on supporting one another. Follow-up studies with CBT can occur more readily if there's a strong relationship formed. Support is the key to success, along with the commitment from the client with both CBT and DBT. Ongoing concerns with both of these treatments that are used more more openly, is that there is lack of knowledge about eating disorders within the Hispanic population, and along with competent providers, both language, culture, and likeness. So again, we go back into that mindset of really being aware of the culture, being able to provide the services in their language, knowing the culture and likeness. I can't emphasize how much I have seen that in the treatment, specifically with eating disorders, how that connection, I think in general, when you're a therapist, that piece of really, pardon my words, looking like someone like me when you're seeking treatment, how much that is necessary with this population. It's more of that, if you look like me and you speak like me and you understand my culture, then you're going to understand where I'm coming from. So again, CBT and DBT have both been the more effective with this population, yet CBT is the one that is, again, used more because of the cultural core beliefs that it can incorporate. When we look at interpersonal psychotherapy, remembering that it is effective when we're working on mood regulation. It is about improving function and improving the quality of life. I think with interpersonal therapy, you have to be a fairly motivated patient and ready for that. And you may need to do the skills work before doing all of the other mood work too. And remembering that interpersonal therapy is about getting people out of isolation. DBT might be able to be incorporated with this because of the distress tolerance skills. It generally works in other areas of life, but with binge eating, it hasn't been shown to work as much. Around the medications, I think that there's still other medications that are being used. I think there's always still a stigma of taking two medications in general, and specifically in this culture, not knowing enough about antidepressants may require a treatment provider that can really be open to sitting with the patient and family and explaining what's required when taking medications. So really having that person that can help you understand how medications work. So as we move towards the end of the presentation, I still have a little more, but wanting to share about the conclusions. Again, I can't stress how there's even working on this presentation for probably about the last 6 months. Some of my research is sporadic. If you look at my references, there are pages that I've had to use to get information. So there's minimal research with this specific population and binge eating. Can't stress enough that stigma with mental health within the culture and how it is experienced. That the limitations of trained professionals with cultural and language specifics hinders the treatment for this culture. And again, as I mentioned earlier, when we were talking about the meal plan and how you may need to adjust it to condiments are different, being able to tailor it as much as possible to the client needs and understanding the role of food and it being part of the culture itself. Can't stress enough the socioeconomic and limits due to this. We need to consider those, take those into consideration. Again, CBT at this point is the one treatment that can be easily translated to Spanish. And as I continue to talk about this population and what I say in general, there's a rise in eating disorders within all ethnic minority groups, and specifically with women. So if if we treat women really looking at what are they really going through? Is their eating disorder more towards binge eating, and if they're being diagnosed with bulimia nervosa, really looking at that it is that ethnic groups are experiencing eating disorders more and more. When I talk about Latinx culture, or the Latinx population, I've treated a few patients here that have experienced or are going through figuring out their gender identity, or have already figured out their gender identity. In general, the struggle is similar to what I've explored with you all around binge eating. What I've noted though, that binge eating disorder, as Hayes has so greatly put it, is about acceptance. So you throw in gender identity in a population that is already struggling with a mental health disorder, and then you throw in gender identity. It makes the services more difficult for a person that is both experiencing binge eating disorder and trying to figure out their identity, or knowing their identity. I can tell you that gender identity is still a difficult topic within the Hispanic population. I don't know if it's all the machismo, or in general it's still very shame-based. And so I think when addressing someone in the Latinx culture, to really proceed with caution, because again, family is such a big part of the culture, and that is where the problem can actually lie. How difficult it is for the family to accept their child as being non-binary, or going through transition. So again, when dealing with Latinx, really we think it's going to take a little bit longer, and then you throw in a binge eating disorder, it may take longer in treatment for this individual. I have to stress that this is a population, again, that there's underuse of services, and it's an ongoing struggle. I think what I read what I've consistently read as I did my research was that it is important to educate the Hispanic population around eating disorders. Do I have an answer on how we do that? No, except I do my best by having these presentations with various people, with various providers, with sharing my knowledge. So as we continue with this seminar, if Lynn wants to give out my information, I'm fine. If you have any questions ongoing that I can answer. Remembering that this is a culture that is, there's got to be some culturally sensitive services provided, and training is very limited. I use the example that sometimes I've gotten calls from my doctor about eating disorders in general, and trying to figure out if a patient is needing treatment. And then you throw in the culture, and people are asking me, what do you think this is? How do you approach somebody that around their weight when it's binge eating and it's a mental health concern? So again, there's limited training and resources and appropriately trained individuals. I have one slide that I wrote it in Spanish for you all, and then I will translate it, because like any other culture, there's a lot of sayings that are related to food. And I wanted to share some of the more common ones that I experience, and we'll translate them to you all. And it's just interesting that as I've done these presentations, I've also become aware of how much, even in my own family of origin, we talk about food and everything that in a lot of ways in common get-togethers. So the first one is panza llena, corazón contento. A full belly stomach makes a happy heart. Number two is hasta la mejor cocinera se le queman los frijoles. We all make mistakes. those burned beans. Even the best cook can burn her beans. The next one, las penas con pan son buenas. Having food leads to less worry. It's a means of comforting someone during a stressful time, reduces our worry and anxiety. I don't know how many times in my own life experience where I've had a tia that lived here in Denver, and I'd be stressed out about something with grad school or something, and she'd say in Spanish, come on over, ven hita, I'll feed you dinner. So having food leads to less worry. It's comforting. Someone, let me reduce your stress. Come have dinner. Camarón que se duerme, se lo lleva la corriente. You snooze, you lose. If you're shrimp and you fall asleep, you're going to be swept away by the waves. The next one, no solo de pan vive el hombre. This is common in all cultures. Man cannot live on bread alone. And then we go to, este arroz ya se coció. That's how you would say, it's a done deal. We're done. It's done. The last one, dale vuelta la tortilla, is, come on, let's change the subject. Flip the tortilla. Let's flip the sandwich. So as I conclude, I show you our different programs. I am in the Denver office where you can see where we're located. I currently work in PHP level of care, although our IOP is combined. So we are 7 days a week, 11, 12-hour days, and open on holidays. We also have Colorado Springs, Kansas City, and Omaha. And the last slide shows that we're an empowerment-based program. As you can see, we focus a lot on connection, acceptance, mindfulness, sense of self, and action. If you ever have the opportunity to come visit EDCare, you will notice that a lot of our group rooms are actually named after our CAMSA. CAMSA occur at EDCare when they are done with our program. They graduate and we do what's called a CAMSA. They receive a lovely leather-bound journal where, as their primary therapist, I would write them a little note, and then they're encouraged to talk with other providers if they'd like a note to take with them as well. So again, CAMSA is a big part of our program, and I wanted to share that with you all. And these are addresses. I'm on Mississippi as we speak. So that does conclude binge eating, trastornos de atrancón. There are my references.
Wonderful. Dolores, thank you. We got to know you a little bit through this presentation as well, and that's really nice. We'll go into some questions in just a second, but I will just make a very brief shout out again for EDCare and all the great work they're doing, as Dolores showed with the CAMSA model. It's really incredible, the work you're doing, and I look forward to visiting as soon as I can. And then also just a reminder to those of you who, and someone is asking for contact information. Dolores, do you want to type your contact information in the chat?
I'm going to type it right now.
Cool. So, and while she's doing that, I just wanted to remind you all about ANID's recruitment, volunteer recruitment season opening again next week. And also it's our 45th anniversary, and we're so excited to celebrate the history of ANID with you with these webinars. And so if you feel inspired by today's free webinar, it would be great if you could drop a few bucks at anid.org/donate. But we will now spend some time and someone is asking about who do we contact for that recruitment. You can just go to our website, ana.org/get involved. And that should get you to our information. And then you can go to ana.org/donate if you are interested in donating. All right, so let's get into some questions for Dolores. The first one that came in was about, this is such a great question. Is there literature in Spanish that you would recommend that can be provided to families that really explain eating disorder in the way, in the culturally sensitive way that you kind of described in your presentation?
I'm going to slide over to my left because I do have, I was handed a brochure that is actually in Spanish that I did not put. I believe I have it with me.
Okay.
Because it was handed to me late.
Oh, okay.
But I bet I don't have it. Because I have everything else. Nita actually does explain it fairly well. I've used their website. Nita does have Spanish resources. So, and then there was another one, and I may have to get it to you, Lynn, if I don't have it here.
Okay, yeah, that's fine. We can definitely do a follow-up email with some more resources.
There's a brochure, and clearly I took it out of my handy dandy because I carry this bag back and forth with my presentation. Yeah. So I will get it to you. I will get that to Lynn. It's a brochure that's in Spanish. It doesn't generally address just binge eating, but eating disorders in general. But Nita is a site. NAMI does a lot of, the National Association for Mental Illness is another one that does put a lot of their diagnoses in Spanish. And so those are two that I would recommend to look up. My resources, there is a book. I look at my resources that's in Spanish that talks about eating disorders, and I mean, you'd have to share it with the family and translate it if you're the one that's talking to them.
Yeah.
But I do have some Spanish speaking resources on my reference list.
Okay, well, great. Maybe Dolores, you can share that with me after this webinar, and then we'll send it around along with the recording. And that's great. And I'm so glad to hear these resources. We'll pass it along to our helpline staff just to make sure that we're aware of these as well. I know we do get a lot of calls from Spanish speaking people, and we currently don't have the capacity to talk with them, but we would love to get to that point at some point. So if you know any volunteers who speak Spanish and would like to cover our helpline,
you never know. You never know. I might be able to help once in a while.
Oh, that'd be awesome. Okay, and then here's another question, and I want to add something to this. Are there any support groups available online for Hispanic families specifically? There's not. Okay.
None that I'm aware of.
So then my follow-up question is, what are your thoughts about BIPOC support groups? We have one. And it's essentially, it's a huge swath of people.
I think I stressed it so much in my presentation that in general, ethnic minority groups are underrepresented or underserved. And so those are my thoughts. I think that those of us that are in this field, I was called a unicorn by someone that wanted supervision. Unfortunately, they were in another state and I couldn't do it because of the laws on supervising. I think there's few unicorns, and we can't be stretched because some of us are committed to certain areas of work. I'm committed to EDCare, and I would bring up, though, I might bring this up to EDCare. How do we provide this? that might be more in a virtual way, because then we would reach more people.
Yeah.
I'd certainly be willing to do one in Spanish.
Yeah.
So might put it out there for EDCare.
Yeah, because
But
that.
I'm not aware. But if we start one, I will let you know.
Okay, please do. Yeah. And likewise, I mean, I think Anna would love to start a Spanish speaking support group. We need someone to step up. And so yeah, okay. So neither of us have a great answer for that question, but
sorry.
We need to keep working on this. And
yes.
And I think webinars like this are so great for spreading awareness of the need for more Spanish speaking volunteers or potential employees. And so if any of you listening today knows anyone with eating disorder experience who also speaks Spanish, please send them to EDCare and/or ANID.
Or both. We'll share.
Or both, exactly. There was another question that came up. Oh, shoot, it was further up. Do you find community supports for single mothers with BED in Colorado? It's a very specific question. Okay.
So clearly I am in the Denver metro area. Yeah. So specifically to Spanish speaking, that again, no. But fortunately, we have a foundation in Denver called the Eating Disorder Foundation, which sponsors a lot of groups. And so often we can refer to the Eating Disorder Foundation. NAMI, actually the National Association of Mental Illness, often does do more ongoing support groups. I think that, if they're college, obviously single moms could be in college, the college counseling centers are always good ones for groups. But in the Denver metro area, and right now the Eating Disorder Foundation is still virtual. So essentially they're covering the whole US.
Yeah.
Are they Spanish speaking? No. So
Right.
there we go again. Although I have volunteered there before.
Yeah. Yeah. But you said, okay, so does Eating Disorder Foundation have something specific for mothers?
Okay.
Right.
Well, binge eating, and there's a variety of groups. So they're eatingdisorderfoundation.org.
Yeah. And we, ANID is hoping to launch a binge eating support group this fall. We're also in recruitment for that. Definitely, because I think there's a growing demand for that. Mm-hmm. And then we also had a question, I'm going to type it in the chat. Do you find it difficult working with patients with comorbid disorders, for example, has an eating disorder and major depression?
I have often said this, and I've been working with eating disorders, 11 and a half years. It's challenging, but no, I don't find, because I also treat substance abuse. So it's almost with depression and eating disorders, it's almost like what came first, the chicken or the egg? Mm-hmm. And then you have to treat them concurrently. You have to treat, is the depression causing the eating disorder? Is the eating disorder part of the depression? So I find them both fascinating, first off, call me odd, but I enjoy the work I do. So treating both concurrently and figuring out is it, in women, we see a lot of the, when I talked about the Mexican woman that I treated, there was postpartum depression that was never treated because she didn't have time to treat the depression. She had kids to take care of.
Yeah.
So you do have to work. I think it's always good to have a good team. Mm-hmm. Somebody that's treating the eating disorder, somebody that's doing the meal plan, and somebody that's doing the meds. That is the part about private practice. I think that those of you that are in private practice, it's important to have a team. And so no, I don't find it difficult as long as I have a team and we're all working together.
Yeah, right. Good. All right, let's see what other, okay. Do you think binge eating disorder prevalence in the Hispanic community is due to the cultural importance of food? In other words, does the view of food and the culture put those in the Hispanic Latinx community more at risk for developing an eating disorder?
No, I don't think it's all about the food. Food is
Hmm.
very important, but as we know, in eating disorders, there's a high percentage of trauma. I tell this to, I'm one of the senior therapists age-wise here, and I often say to some of the therapists that I work with that in my experience, I think the last I had read, it's like 65% of people with eating disorders have experienced trauma. From my experience, it's more like 90% of patients with eating disorders, if not more, have experienced some form of trauma, even if it's someone saying, boo, you are ugly, or somebody that's super sensitive is going to see that as trauma, and it is traumatic. And so it's not all about the food. I don't think it puts that's the risk factor. Just like all the other eating disorders, you look at what else is contributing to the binge eating. And the Hispanic patients that I have treated have extensive trauma. I mean, crossing a river with a child is not an easy thing. So no, I don't think it's all about the food. You explore more of what's underneath the food. I often say that to my patients, whether they have binge eating disorder, anorexia, bulimia, that Thanksgiving isn't about the food, it's about the emotions.
Sorry, I'm just reflecting on what you're saying. Because I come from, we were talking yesterday, Dolores, I come from a Jewish heritage, and food is so central, but in a very different kind of way, like more of a guilt-ridden way, at least in my own lived experience. And so for me, the answer to that question is yes, but I can see, but I think it's because of the emotions. Again, what you're saying is the
Exactly.
emotions. Like if food were more celebratory, the way it is in the Hispanic culture, then yeah, it would be a different story.
If I connect it, to answer that question, if I connect it to my own experience with food, in that I can go and make tamales, and we can make several dozens. You just don't make 1 dozen of anything in the Hispanic culture. I don't eat them because I don't like spicy food. So it's not about the food there. I just don't like spicy food.
Right.
Well, the majority of my family members do.
Mm-hmm.
It's a preference.
Yeah.
So it's in that, look underneath the food.
Yeah.
It's a lovely culture. I will tell you that.
Yeah.
I wouldn't change anything about it.
Yeah. Yeah. Well, okay, let's see if there's any other questions. Well, I don't see any specific, but I like to close these webinars with kind of any advice you have to someone who is like just starting out, getting to know this population, very interested in doing good work, possibly in school. What advice would you have for someone to working with this population?
Well, first off, I never planned on becoming an eating disorder therapist, to be honest with you. Obviously, my undergrad degree was to teach, and to teach Spanish at that. And then I went on and got my master's. I think the biggest for me in working with my own gente, my own people, is about that relationship that you can form And if it's trusting, you will have a patient that will do all the work themselves.
Mm-hmm.
You guide them, they trust you, they do good work.
Mm-hmm.
So it is about, with the Hispanic culture, it is about the relationship you have. It's reinforced even more because in therapy, it is about relationship in general, but you throw in culture.
Mm-hmm.
That is about relationship. You have to have that relationship. Because if you don't have the relationship, they won't come back.
Right, right.
They won't answer the phone.
Mm-hmm.
So really, really work on that relationship.
Yeah. Yeah, that is such good advice. All right, well, we are going to close this out with just another big thank you to EDCare, to Dolores. Look, I put her email address there so you can all follow up with her. We will send out the recording to this. It may take some time because of a technical glitch. It's the video is in 2 pieces, so we'll get that out as soon as possible. And then Dolores, if you want to send me any resources that I can add to the email when we send out the recording, we can do that. And again, you'll receive an email tomorrow asking you to take an evaluation so you can get your CE credits for this great webinar, and it should satisfy a culturally competency requirement for continuing education, which is wonderful. So Dolores, thank you so much again for doing this.
Thank you.
Yeah.
Gracias. Thank you.
Gracias.
Muy amable. Buen día a todos. Have a good day, everyone.
Yeah, thank you. Thank you, everyone. Have a wonderful day, and we'll see you again soon for another webinar. In the meantime, please do drop a donation to ANID or consider getting involved as a volunteer. Thank you, everyone. Bye-bye.
Bye.